Hey, thank you so much. So for the record, my name is Kathy Way, and I'm the Legislative Director for Representative Alyssa Keny-Guyer, who cannot be here today. She is on the quick road to recovery, and so she just, again, is so thankful that this bill is being heard. She passionately and strongly supports House Bill 2011. The district that she represents is one of the most diverse census tracts in our entire state of Oregon. Many immigrant and refugee communities have been living there for many, many different decades. And she also has had the honor and the pleasure of working with many community-based organizations, particularly in that district, that have been, very much challenged by cultural and language barriers when it comes to healthcare access. And so we are just, it's going to be a quick testimony, but if she was here, she would be passionately talking about it. I know that she's also trying to view live stream online. So she's, again, just much in favor of 2011. She was also one of the co-chief sponsors on the bill back in 2013 with Senator Jackie Winters. And again, we cannot emphasize just how important it is for all of our healthcare professionals that are serving Oregonians to have the proper training and education around cultural competency. And if we can also offer a personal anecdote, I think for me, I came here with my family when I was 6, and I played the role of interpreter and really, the interpreter for many of refugee families that have come here recently. And so I just know the importance that having the proper training is an advantage to our healthcare workforce as well to our healthcare system overall. So with that, we hope that you will continue to support 2011. Thank you.
Thank you. Hi, good afternoon. Chair Salinas, members of the committee. My name is Dr. Xenia Junkier, and I'm the director at the Oregon Health Equity Alliance. We're here in support of HB 2011. As a physician, I think it's unacceptable for a healthcare delivery system to not be able to meet the needs of its patients, its members, and its constituents. Studies show that Black, Indigenous, people of color, LGBTQ folks, people of lower economic status, and people with disabilities are less likely to receive adequate healthcare due to cultural and communication barriers. As a physician, we learn to explicitly how to diagnose and treat disease. However, historically, there have been limited opportunities to understand the roles of racism, colonization, toxic health, and chronic illness as they relate to the social determinants of health. When I was in medical school over 10 years ago, there were little to no opportunities to access courses that were culturally and linguistically responsive, or even courses that were elective. So without access to that, basically everything that I learned was through a framework of cisgender, heterosexual, white, urban, able-bodied populations. And I often share a story about my dermatology class where the textbooks only showed any sort of dermatological conditions on white or fair skin. I share this often because while I don't feel particularly young, I've been out of medical school now for 9 years, I know that there are many others who came before me who are leaders in our field who also did not have access to any of these frameworks or models or even information about how we understand that disparate patient, provider, race, and ethnicity identities can absolutely equate to inequitable health outcomes in our patient populations. I've heard from many patients, friends, and community members that they felt misunderstood, disrespected, and undervalued by their providers who don't share a lived experience, whether it's race, ethnicity, culture, etc. Again, these disparate racial identities, we know the literature shows us, the data shows us, and more importantly, our community members can tell us that they are not getting the treatment that they deserve because their providers are unable to understand their lived experiences or unable to understand how their own bias shows up in clinical care settings. Culturally and linguistically responsive healthcare improves the most core and foundational component of our healthcare delivery system, the care, one-on-one, that we provide to our patients. When patients receive care that is as free as possible of bias, responsive to their needs, and acknowledges the structural and systemic racism and bias that occur, we not only ensure better health outcomes for our community, further reducing costs, but more importantly, we secure meaningful access to culturally responsive care, which should be a standard in the care that we provide. HB 2011 strives to reduce health provider bias, improve health literacy, and support provider-patient relationships by providing an essential tool to all licensed health professionals. Thank you for your time today, and I hope to see you in support of HB 2011.
Thank you.
Chair Salinas and members of the committee, Elizabeth Remley here today on behalf of two provider groups, the Oregon Society of Physician Assistants and the Licensed Professional Counselors and Marriage Family Therapist group. The OSPA has put a testimony on the record. I'll direct you to that. And then focused on where the physician assistants are on this. OSPA is really in support of this as a growing primary healthcare provider group, actually one of the fastest growing professions in healthcare in the state of Oregon. They are a huge part of the future of healthcare in this state. They're doing everything they can at OHSU and Pacific to educate their providers to be culturally competent, but some of our more veteran and senior members of this profession probably didn't get that in school, and so continuing education is a way to do that. Ensuring that all Oregonians have access to healthcare that is culturally respectful is extremely important. And as our state gets more diverse, especially in the Portland area, but also in Southern Oregon and Eastern Oregon, I think it's really important that we have a provider group that knows how to interact with their patient populations, some of whom are new to the area, and those demographics are changing pretty rapidly. So we are fully in support of this. We really appreciate Speaker Kotek working with us to make this CME requirement work for our providers. The -1 amendments and then amendments that OMA has been working on, we're in support of as well, because that flexibility is really important. These providers also have to take a lot of other CMEs that help them do their jobs in their space. And so we want to make sure that anytime the legislature passes a CME mandate, that it is the appropriate solution for the problem that somebody's identified. In this case, House Bill 2011 is that. And then for the mental health counselors and therapists, they have the same they have the same comments. I will, if you guys are curious about what a cultural competency CME looks like, there is testimony on OLIS from Deb Marinos, who teaches a cultural competency class around dealing with patients with blindness. She talks about a lot of things on there that I had never thought about, that you had never thought about. In fact, might even be helpful if you have constituents come visit you who are hard of seeing, because those tips that she includes in her letter will be helpful to you too. So anyway, I hope that you will support House Bill 2011, and I appreciate your time. Thank you.
Thank you. Questions for this panel? All right, thank you.